Hello, everyone. I'm Mathura Kannan, a junior in Florida, and today I'm here to talk about something that affects nearly 470,000 children in the United States: pediatric epilepsy. If you've ever seen someone have a seizure, you know how scary it can be. But what you might not know is that for 30% of kids with epilepsy, traditional medications just don't work well enough. That's called drug-resistant epilepsy, and it's a huge problem. Everyone, meet John. He's one of the 470,000 kids in the US with epilepsy. He's also one of the 30% that has drug-resistant epilepsy. But what does that mean? Epilepsy is a neurological disorder that affects both adults and children, and is essentially when your brain's electrical signal systems go haywire, causing seizures. Think of your brain like a computer. Normally, all the electrical signals flow smoothly between neurons. But in epilepsy, there might be a few wires out of place, or too many electrical signals heading to the wrong place, which is what causes seizures. This can mean anything from briefly spacing out to full body convulsions. Now, doctors have been trying to treat epilepsy for over 150 years. If John was born back in the 1800s, he would have gotten potassium bromide, the very first anti-seizure medication, ASM. Of course, it had terrible side effects, so scientists kept experimenting. The medications we consider first generation come from between 1912 and 1978 and include phenobarbital, phenytoin, ethosuximide, and valproic acid. While they could stop seizures, they also came with some awful side effects. These include dizziness, nausea, depression, liver damage, kidney problems, and even nerve damage. If John were around at this time, he'd have to choose between having seizures or feeling sick and tired all the time. That's why scientists developed second generation ASMs starting in the 1980s to the 2000s. This time, they went through more rigorous placebo-controlled trials. As a result, they are generally better tolerated and have less side effects in comparison to the first generation ASMs. They also include favorable pharmacokinetics and less interactions in the brain, meaning that they essentially only affect the parts of the brain that they are meant to affect, which is one of the reasons why they have less side effects. Now, let's talk a bit more about this bolded ASM, Levetiracetam, brand name Keppra. So what makes Keppra special? Well, unlike older medications that work by blocking certain channels in your brain, Keppra works by binding to a certain protein called SV2A. When Keppra binds to SV2A, it helps stabilize the release of GABA, the main chemical that calms down overreactive neurons, also known as an inhibitory neurotransmitter. This figure shows a synapse, gap between neurons where electrical signals and chemicals are sent from neuron to neuron. And the results of Keppra, they're pretty impressive. In studies with over 350 kids, more than 63% saw their seizures reduced by 90 or more percent after a year on Keppra. That's huge. Plus, the side effects are generally manageable. Mostly things like irritability or hyperactivity, which can often be fixed by adjusting the dose. But here's where things get really interesting. There's this treatment that's been around since the 1920s called the ketogenic diet, or the keto diet. Now, it may be a bit odd at first to think that a diet could help with epilepsy, but dietary therapy is serious medicine. The keto diet is extremely high in fat, very low in carbs, and moderate in protein. It's about a 1 to 4 ratio or a 3 to 1 ratio of everything else to fat. That means if you're on this diet, you might be eating things like heavy cream, butter, oils, while avoiding bread, pasta, and even most fruits. When you eat almost no carbs, your body starts breaking down fat into these chemicals called ketones, shown here. Your brain can actually use ketones for fuel instead of the usual glucose. This change in brain fuel leads to more glutamate, the brain's main excitatory neurotransmitter, which then allows more of it to be converted into GABA through the protein enzyme glutamate decarboxylase, or GAD for short. The results speak for themselves. In a study of 972 children on the ketogenic diet, 56% had their seizures reduced by more than half, and 16% became completely seizure-free. That's pretty amazing, especially when you consider that these are often kids who didn't respond well to medications. Now, here's my main research question. What if we combine these two treatments? What if you gave kids both the Keppra and the keto diet? Keppra works by stabilizing GABA release through SV2A binding, while the ketogenic diet increases GABA production by converting glutamate. The early evidence suggests that this combination could be incredibly powerful. Both treatments work on the GABA system, but in different ways, so they might amplify each other's effects. Plus, if the combination works better, kids might need lower doses of medication, which means fewer side effects. Here's our fictional case study, John again. He's been having seizures since he was little, poor guy, and he's got drug-resistant epilepsy, so no medications really worked. Seizures are unpredictable. They could happen during a math test, during a sleepover, or while he's in PE. His parents are constantly worried, and he can't participate in normal activities that other kids take for granted. If he starts the keto Keppra diet, it would increase his GABA production and stabilize its release, and it could help John live his life like any other kid. Of course, this isn't without challenges. The ketogenic diet is really restrictive. If he does the combination therapy, John wouldn't be able to eat pizza or birthday cake with his friends. The keto diet also requires constant monitoring and can cause side effects like constipation, kidney stones, and growth issues if not managed properly. And we still need more research to prove that the Keppra keto diet combination is both safe and effective. Pediatric epilepsy is a serious condition that affects hundreds of thousands of families in our country. While we made incredible progress with anti-seizure medications, we can't ignore the 30% of kids who struggle with drug-resistant epilepsy. With their complementary mechanisms and early research behind it, I propose that Keppra-keto combination may yield more benefits in pediatric populations, especially those that are drug-resistant, than an ASM would do alone. Of course, this research has its limitations. While there have been a couple of studies on the Keppra-keto combo in an adult population, there's a lack of studies in pediatric populations. There's also little data on potential drug-diet interactions. Is it hard to make ketosis while on Keppra? What we need now are large-scale clinical trials specifically designed to help test Keppra and the ketogenic diet together. We need all answers to all the questions and limitations on the last slide, and so much more. We need to figure out the best timing. Should kids start both treatments at once or add the diet later? What's the optimal dose of Keppra when combined with the diet? And how do we identify which drug-resistant pediatric patients are most likely to benefit? So much more to learn, but we have time to do it. Thank you for listening.